Stroop test. Scores on global assessment functioning was significantly lower in bipolar disorder patients, indicating that there was overall functioning was poorer when compared to controls. And the executive dysfunction independently contributed only partially towards predicting functioning after controlling for illness duration. The limitations of the present study is the sample size, which was only 20 cases and the 20 controls. And the premorbid intelligence, which could have a effect on the performance on cognitive tests, was not taken into consideration. And the patients were currently using medications like mood stabilizers and antipsychotics, which also influence the performance on executive function tasks. So the future implications, along with pharmacotherapy, if cognitive remediation is also applied, overall quality of the life can be improved. And with a larger sample, the results of the present study can be validated. Thank you.
Yes, any questions, please?
Ka, pa, ma.
Sir.
The more
Can
logical thing would be, one is ka, another is cha varga, means cha cha ja jhai. Another is ta varga, ta tha da dhana. Another is ta varga, ta tha da dhana. Either of them. Another is pa varga, pa bha ba bha ma. Pa and ma belong to the same category. Why? Because ka varga comes from the neck. Pa varga comes from the lips, labials. Ta varga, ta tha da dhana. That comes from the
Dr.
dental.
Sharma garu,
That's all.
please put the, take the question, madam. Why did you choose particular?
So these were the tests, like the neuropsychological battery was included from the NIMHANS neurocognitive battery of 2004. So those were the variables used for control oral word associations test for English language, FA and S and in the mother tongue
Yeah.
Kapama.
So Telugu version for FAS. Okay.
It's not from in their mother tongue Kapama.
It is all Indian languages, including English and Latin.
Sir, some of the cognitive tests, the minimum age for like on this neurocognitive test was 18 years. So we included from 20 to 50 years.
Dr. Chaudhary.
Do you think an average person is capable of generating that many words as in English? And you didn't give a comparison between the two, so.
So, but most of the patients or the control groups name the animals in English itself.
But statistics vary. You haven't mentioned that, so your study becomes a little shaky on that.
Dr.
Okay,
Anand
we'll take into
wants to make a comment. Sir.
Yeah, this is regarding the slide which I've shown on multiple regression, where the standard error is quite high. Whenever the standard error is quite high, interpretation of results should be guarded. In the sense, you cannot just generalize and say, this is only, what is your explanation, since I have to ask only a question.
Sir, actually the illness together with the clinical value.
Okay. I have one question. Are these tests, are they validated in our regional languages, the tests you have used?
So
Are they
these are
validated tests? Okay. And did you make a power calculation before undertaking the study? How much sample is required?
So no, sir, the power calculation was not done. That is one of the sample size was one of the limitations for this study.
Okay. Thank you. I think we.
If there are no more questions, we will conclude this session, and I thank the organizers for giving this opportunity to chair these sessions. Thank you.
I have to say both these presentations are very good. Methodology is good, really. I really congratulate them, whoever wins the award.
Chairpersons will change. Okay. Now I request Dr. Anurag sir to please give the mementos to Pramod sir and Kesharov sir. It's Dr. Sita Ramaya and Krishna Lila PG Award, and I request chairpersons Dr. Anand sir and Dr. MBR Sharma sir to please preside over the award. And the entries received are from Dr. Shalini IMH and Dr. Bhaskar Katram IMH and Dr. Sadhvi Maithili from Asha Hospital.
Thank you, the organizers, for calling us to chair this session. Dr. Sita Rama and Krishna Lila PG Awards session. The first presentation is study of sexual dysfunction of female patients attending psychiatric OPD by Dr. Shalini. Kindly come and present.
Good afternoon, one and all. I'm Dr. Shalini from IMH, and today I'm here to present the paper. Topic is study of sexual dysfunction among female patients attending the psychiatric outpatient department. My plan of presentation would be first few words about background, then methodology of my study, results and discussion, conclusion, limitations and declarations. Coming to the background, sexual dysfunction can be defined as the persistent impairment of a couple's normal or usual patterns of sexual interest and or the response. The sexual dysfunction is common among the general population as studied by Lawman Rosen et al. In 1999. It should to be affecting 43% of the women and 31% of the men. Female sexual dysfunction as such is a complex, multifactorial and multidimensional clinical condition with many etiologies and many pathophysiologic correlations. It's highly prevalent and it has a major effect on the quality of life. But however, the reliable estimate of the incidence and severity of sexual dysfunction in females is difficult to obtain because the patients are unwilling to raise or discuss the issue of sexual health with the health professionals. And also, the healthcare responding to this healthcare need is equally challenging for physicians because of the limited time and insecurities about how and what to ask, and also the lack of knowledge about the therapy options. And due to lack of sexual therapies and limited options for continuing the education result in underdiagnosis and undertreatment of female sexual dysfunction. It is a common problem among women of all ages and has negative effects not only on their quality of lives but also on the sexual function and quality of life of their partners. It can also affect the mental health of the entire family and in turn the society. And keeping in mind the multidimensional nature of female sexual dysfunction and its consequences, it needs to be recognized in its early stages in order to prevent future consequences and its impacts. But there are only a few studies about the sexual dysfunction among females in India, and in the Indian culture, talking about sex and its related issues is a taboo, and spouses are still uncomfortable in sharing the problems with each other. The scientific community in India has been indifferent to the area of human sexuality and its problems. Sexual dysfunction has reported to constitute about 9.2% according to Nakra et al. In 1970 and 13% according to Bagadia et al. Study in 1972 of the psychiatric outpatients. So from public health perspective, there are no large-scale data available. Hence, this study has attempted to identify the association between mental illness and sexual dysfunction among the females. Aims and objectives. It is to assess the sexual dysfunction among the female patients attending the psychiatric outpatient department, to study the relation of mental illness on sexual dysfunction of the patient, and to study the influence of socio-demographic profile on the sexual dysfunction. Patients, the females who were diagnosed to have psychiatric illness and who gave consent to the study were included. Sexually active females between the age group 18 to 60 years were taken, and who had sexual activity during the past 2 weeks of the study. and the patients who have not given the consent, and the subjects who are diagnosed with any other medical condition that can cause sexual dysfunction like diabetes mellitus or any spinal cord injury were excluded, and the subjects who were diagnosed to have mental retardation and who were aged below 18 years and above 16 years and sexually inactive females were excluded. Study design and the place. This is a cross-sectional comparative study done in the outpatient department of the tertiary care psychiatric hospital located at Hyderabad, Telangana. Sample collection and size. All the female patients attending the psychiatric outpatient department were selected randomly till the sample size reached 100, and 30 control females would be studied from the community who had no diagnosed mental illness. The respondents were classified as having sexual dysfunction if the SX total score was more than 18, which ranges from 5 to 30. The study instruments used were initially informed consent would be taken from the patients or the patient's attendant, and the semi-structured socio-demographic questionnaire including the patient details and the illness details are noted. Arizona sexual experience scale was administered by translating the questions to the patient's local language because all the questions are in English. The history of the scale in detail, SX Arizona sexual experience scale. It's a 5-item brief questionnaire diagnosed to measure the sexual functioning among both males and females in the following domains: sexual drive, arousal, penile erection in case of males and vaginal lubrication in females, ability to reach the orgasm and satisfaction of the orgasm over the past 1 week. It was first developed by McGaughy et al. In the University of Arizona, and it was first developed to study the influence of mainly serotonin, selective serotonin reuptake inhibitors on the sexual dysfunction in mental illness patients and end-stage renal disease. All the items are rated on a 6-point scale ranging from 1 to 6, 1 indicating the hyperfunction, that is extremely easy, and 6 is the hypofunction, very difficult, providing a total scale range of between 5 and 30. The scoring, a total score of more than 8 or a score of more than 5 of any single item or any 3 items with individual scores more than 4 are considered to be clinically significant sexual dysfunction. The statistical analysis was performed using SPSS for Windows. Group comparisons, patients and controls were made using the student's t-test and chi-square test where appropriate. Pearson's correlation coefficient was performed to examine the possible relationship between the SX scores and clinical variables, and ANOVA was also done where appropriate. The socio-demographic details of the sample were a total of 92 patients were collected and 30 controls. Most of them were Telugu-speaking females, accounting to 80% of the patients and 80% of the controls. Most of them were illiterate, accounting 57.6% among the patients and 33% of the controls. And most of the patients and controls belong to the lower socioeconomic class since it was done at a government setup. And most of the sample population were unemployed or housewives. And various mental illnesses with their percentages among the studied population. Schizophrenia was the highest, accounting to 63.4%, then mood disorders 33%, only 3% of substance use disorders and 7% of anxiety disorders. Here there was no statistical significance with the SX score was associated when studied. The SX scores between the groups, between the two groups, that is patients and controls, the mean of SX score was 17.62 in patients and 16.7 in control group, but it was not statistically significant as done by the t-test. ANOVA has also showed no significant variability with the variables both within the group and in between the groups. This Pearson's correlation test has also not shown any statistically significant correlation between the variables and the sexual dysfunction among the females both within the group and in between the groups. Conclusion of this study is it has shown that there is no statistically significant difference of sexual dysfunction between the patients of mental illness and normal controls, though the sexual dysfunction rates were high among the studied population on whole. This study is not on par with few other studies available. The reasons could be many of the available studies, of course very few available, have compared only a single mental illness like depression versus the normal patients or patients of schizophrenia versus the normal group, but not all the mental illnesses were not considered as a single group. So that could be the reason of disparate results. Limitations, all the patients were on treatment, so psychotropics are known to cause sexual dysfunction. So the reason of sexual dysfunction, which could be because of psychotropics, was not excluded from the study. And being a cross-sectional study, the cause-effect relation could not be established, and also the pre-morbid sexual functioning was not taken into account. Throughout the study, ethical considerations and non-intervention with the proposed treatment was observed, and confidentiality was ensured. Informed consent was taken prior from the patients or the accompanying nearest relatives. There is no conflict of interest. Thank you.
So now the paper is open for pointed questions only, without any comments. Yes. Can somebody give the mic?
I am Dr. Shishkumar, trying to learn psychiatry. I want to know, you said in the inclusion criteria, some sexual activity before 2 weeks prior to the study. What do you mean by sexual activity? It's a very vague term. What exactly you mean by sexual activity, and what did you ask the patient? What did they answer? Thank you.
Sir, I have asked about the intercourse, sir. If they had any intercourse during the past 2 weeks. I should have mentioned.
Anybody, any questions? I would like to ask a question, that is regarding analysis. Instead of using t-test, why did you use ANOVA?
Sir?
Instead of using t-test, you have used ANOVA. Can you explain the reason?
Sir, for 2 or 3 groups. To compare the variables between more than 2 or more than 3 groups, we have used ANOVA. Like for the in variance of scores, SX scores with the socio-demographic variables.
Any more questions?
Sir. Sir, few of them were the nursing staff there, sir. Few of them were the attendants, like class 4 employees of the hospital, and few of them neighbors and family members. All mixed.
Thank you for your presentation.
Thank you, sir.
And we call upon the next speaker. The paper for presentation is Biological Rhythm Disturbances in Patients with Bipolar Disorders in Recovery. Dr. Bhaskar Katram.
Good afternoon, everyone. I'm Dr. Bhaskar from Institute of Mental Health, and my topic for discussion is biological rhythm disturbances in patients with bipolar disorder under remission. My plan of presentation is introduction, background, aims and objectives, methodology, results and discussion, limitations and conclusions. So, biological rhythms, the examples for that like sleep, appetite and going to work are very important aspects which govern the human life. The bipolar affective disorder patients have a lot of issues which affect their psychiatric illness and its course. So, the study of their impact may help in improving the compliance with better quality of living, thus reducing the need for hospitalizations. So, for that, usually the bipolar disorder, which is a major mental illness and is a significant public health concern, was usually understudied compared to other mental health disorders, according to Hyman 2000. Disruptions in the internal biological rhythms may be responsible for the mood shift experienced by the bipolar disorder into individuals. According to social Zeitgeber theory of mood disorders, life events that disrupt social Zeitgebers are defined as daily social rhythms that are hypothesized to disturb circadian rhythms. This will cause precipitation of bipolar symptoms and increase the risk of relapses. Social rhythms are defined as like attendance at work, engagement in various social activities or recreation and exercise, which definitely affect the circadian regularity. There is a delayed circadian phase of melatonin secretion which is reported in euthymic bipolar patients and depressive patients. Sleep disturbances and instability of circadian rhythms continue when disorder patients are not acutely ill too. Holland and Thays had suggested that individuals keeping regular daily schedules might be able to invoke an artificial control over the biological rhythms and may promote internal synchronization of the circadian rhythms in individuals at risk. Genes and their polymorphisms are also considered to affect the molecular and the biological clock. Individuals at risk for bipolar disorder like hypomanic personalities and subsyndromal bipolar symptoms also exhibit a lower social rhythm regularity. There are very few studies which have assessed the biological rhythms in remitted bipolar patients. Most of them investigated the sleep function exclusively. So main objective which I was thinking about was to study the socio-demographic profile and the clinical variables of the bipolar disorder patients who are under remission. The current study was carried out to assess the biological rhythms in remitted patients and also to investigate the possible correlations between biological rhythms, clinical course of illness and residual mood symptoms in an Indian psychiatric hospital setting. The methodology: the sample size consists of patients, 30 patients who were enrolled from the tertiary care hospital in Hyderabad, Telangana. Informed consent was taken. The inclusion criteria was age greater than 18 years and fulfilling the diagnosis according to ICD-10 for the bipolar affective disorder. They were and also meeting the remission criteria defined as like score less than 8 on the 17-item Hamilton Depression Scale and less than 5 on the YMRS Young's Mania Rating Scale for at least 2 months prior to the assessment. 30 control participants were matched according to age, gender and education with no psychiatric disorders. Both patients were recruited from the hospital catchment area to ensure similar socio-economic pattern between the groups. So the main instrument which was used was the biological rhythm interview for assessment in neuropsychiatry, which is known as BRINE. It is a tool to assess the biological rhythm disturbances. It is an 18-item interviewer administered instrument which allows us to investigate the main areas of frequency of problems related to the maintenance of circadian rhythm regularity. Scale was translated into the local language for better understanding of the patients and the participants. The main 4 domains which were examined were the sleep, how the sleep pattern was in these patients, the activities of their household work, their work duties, physical activities and the sexual relationships. Social rhythm referring to the main ability to concentrate on the social activities and the interpersonal relationships. Eating pattern refers to the capacity to maintain regularity of their diet patterns. So the study time frame refers mainly to the prior 15 days assessment. The scale provides with each item where the rater can evaluate the frequency of difficulties experienced by the patients in comparison with circadian rhythms of a person of same sex, age and social cultural status. The socio-demographic questionnaire which I asked for various patients and the participants. So in the results and discussions where the tabulated form where you can see demographic characteristics of the sample, where 37% of the population which was patients were females and 63% males. Literate were about 70%. Marital status where married was 67% of the patients. Family history 6.7% and comorbidity was around 23.3%. And mainly the correlations where we could see the significance was the total duration of illness with the total number of episodes, where there was a positive correlation between the two. Then based on a table depicting the student t-test across the 2 groups, where there was significant results with all the 4 domains, that is the sleep, activity, social and diet, as well as the total. where we could see that the patients had 23.37 with a standard deviation of 2.76 and 18.43 in the controls. So the scoring was like 1 to 4, where the lowest is the 18 and the highest is 72. So most of the controls were falling around 18 to 20, and the patients had a significant difference of like showing about 23.37. A graph showing where the mean value was for the two patients and the controls in the Bryant total score. And there was also a significant correlation among age of onset in years with Bryant activity, a positive correlation with a significance of 0.003, and Bryant social, where it was significant, and the Bryant total scores also. These all showed positive correlation with the age of onset in years. The main limitation for my study was the sample was small. Although Brian is an interview administered instrument, it was based on mainly the patient's self-report. This was a cross-sectional study which does not allow to determine the direction of relationship between circadian abnormalities and mood symptoms. Hence, longitudinal studies are needed to clarify this issue. The main conclusion, the study showed that there was biological rhythm disturbances which are common in bipolar phases, suggesting an important link between rhythm instability and bipolar disorders. Specific psychosocial interventions need to be applied as a part of supplementary therapy for maintenance of the treatment in bipolar patients to improve the quality of their living and help in reducing the hospitalizations. Supplementary therapies like interpersonal social rhythm therapy can be applied for such kind of situations. Further studies need to be done to investigate the possible correlations between Brian and objective measures. So mainly this was on a subjective basis where we had studied, but on objective measures like polysomnography or actigraphy, where it is like the motion sensors now we are using for daily activity purposes, which can be helpful in monitoring the sleep, activity and their work process, might help in getting us better results. And throughout the study there was no pharmacological or no psychological interventions done, and informed consent was taken. Thank you.
So now you can ask your questions.
I was just wondering on two issues. You said you took remitted patients, and they should be remitted on the remission criteria for at least 2 months. Now, on that scales, and you are assessing only biological functions, and most of these scales are driven at least by the sleep and appetite as well. So, once you are assessing that as a parameter remission, finding there will be dysfunction in at least the biological correlates of this thing is a difficult question. And the last one which I'm worried is that you said that during the 2 months period, is that the 2 months period you said they were not on any medication, pharmacological or psychological? What is the last word I?
No, sir. During the examination, we didn't do any kind of interventions to change their biological pattern or anything.
Your examination scale will take how much time? So during that time you don't do any psychological, pharmacological, isn't it?
No,
so these are that's a more of a question. I didn't understand it. See, during the study period, your words are, during study period, no pharmacological or psychological intervention was given.
They were already on their medications which were going on, but since 2 months they were under remission, which we tested based on HAM-D and YMRS, and then
they were under pharmacological intervention.
Yes, but we don't do any intervention at the time of administering the scales.
First question, so they're already in remission for 2 months, and you're checking whether sleep is disturbed or appetite is disturbed and all. Already you're expecting. And what is the score? Because see, this is a semi-quantitative score or it's a qualitative score? You said it's interview based,
yes,
based on patient subjective report. Did you quantify the sleep disturbance or appetite disturbance, and how did you give a score?
Based on that, it is scale. The scale gives a score based on that, like 1 saying not at all, and seldom for 2, and 3 if it is very often, and more often it is a scale of 4. So based on in the prior 15 days, whatever their problems was, we asked them questions based on that, and the scaling was done regarding that accordingly.
Any more questions?
If there are no more questions, one small comment in appreciation of the paper. Even though it is artificial control, he said that it is going to be useful. The sleep, if a patient falls asleep at the normal time and wakes up at the so-called normal time and eats at the normal time and all, it makes us recall the wordings of Lord Sri Krishna in Bhagavad Gita, Yukta Hara Viharasya. So even though it is artificial, it is going to be useful. That is what it means to say. Do you?
The only thing which I want to ask is that how many other variables which interfere with the biological rhythms were controlled?
Mainly
Because biological rhythms, they vary in so many conditions. In fact, they are the most common type of variations which you will find in any medical disorder also if somebody is on stress also.
mainly in this issue, like there are other variables which might be affecting, like the morning time or evening time. Main thing, like even during the interview process, I made sure that if we take interview in the morning, it might be a problem because some of the patients might be having some kind of mood disorders which are more precipitated, so they might report in a different way. So I made to reduce that kind of thing, I tried to interview them most of the time in like in the afternoon around 12 to 2 o'clock, so that I could reduce any kind of other impact while interviewing.
Thank you for presenting these papers, and I thank the organizers for giving this opportunity to us. One more. Oh,
Thank you.
I saw only the one side of the paper. Sorry for that. The next paper is on metabolic syndrome in long-term inpatients in psychiatric rehab. Dr. Sadhvi.
Good afternoon. This paper is about metabolic syndrome in long-term psychiatric inpatients. Metabolic syndrome is named as a cluster of metabolic risk factors which increase the likelihood of other long-term non-communicable illnesses. It is a pro-thrombotic and pro-inflammatory state which is considered as a red flag sign and doubles the risk of other diseases like diabetes mellitus, cardiac disease and stroke. It reduces the life expectancy by 20% and the mortality gap would be 20 years. And 20% of normal Indian adult population are diagnosed with metabolic syndrome. There are various defining criteria to define metabolic syndrome, but the key components in all the criteria remain the same. Central obesity is the most important factor in formation of metabolic syndrome, and because central obesity is more reliable than BMI as it indicates only fat content in the body, and also the central fat is insulin resistant. So it forms the most important thing, and patients with chronic mental illness or especially are at increased risk of metabolic syndrome because of antipsychotic usage for long term and lack of physical activity, increased prevalence of smoking in the population, and lack of awareness about the dietary factors. And other genetic factors might also contribute to increased risk of metabolic syndrome in this population. And the studies also show that there will be a dysregulation of cortisol and disruption of the hypothalamic pituitary adrenal axis, which is found in schizophrenia and also seen in metabolic syndrome, and this is also contributing to the increased risk. And antipsychotic usage, action of antipsychotics on 5-HT2 and histamine 1 receptors is considered to be responsible for increased risk of metabolic syndrome, and the highest risk is seen with clozapine, olanzapine, and moderate is seen with risperidone, chlorpromazine, and quetiapine. And since 2003, FDA has made warning of diabetes on antipsychotics mandatory. aims and objectives of the current study to study the prevalence of metabolic syndrome in a long term in patients with chronic mental illness, and also to study the correlation of usage of antipsychotics and metabolic syndrome in mentally ill patients. Materials and method: a cohort of patients who were on a long term stay in a rehabilitation center and who were on antipsychotic medication were included in the study. The duration of the stay and the choice of the medication was decided by only treatment team, and the study had been approved by the institutional ethics committee. Inclusion criteria was patients with minimum of 6 months hospital stay and minimum with 6 months antipsychotic usage, patients with a diagnosis of schizophrenia spectrum or bipolar, and patients who gave informed consent. Exclusion criteria was any other diagnosis other than bipolar or schizophrenia and who were not on antipsychotics for minimum of 6 months and the stay for less than 6 months. And the sample, the 74 adult mentally ill patients, in which 32 were female and 42 were male, who were on antipsychotic medication with different diagnoses and with a minimum 6 months stay in the rehabilitation center, were assessed for the presence of risk factors for metabolic syndrome. Tools for the study: a semi-structured proforma which included socio-demographic details and details of the illness and details of the treatment were taken. And for this study, International Diabetic Federation definition of metabolic syndrome was taken, and in which central obesity forms the key component. Central obesity in Indian population is defined as more than 35 inches of waist circumference in males and more than 32 inches in females. And along with that, at least 2 of the following 4 factors must be present. They are raised triglyceride, which is more than 150 mg per deciliter, reduced HDL cholesterol less than 40 mg per deciliter in males and less than 50 in females, or history of treatment for dyslipidemia, raised blood pressure more than 130 systolic or more than 85 diastolic, or history of treatment for hypertension, raised fasting plasma glucose more than 100 mg per deciliter, or treatment history of diabetes. Results: the socio-demographic data, male patients were total was 74 and male were 42, female were 32. The age range of the total population was 27 to 70 and the mean age was 42.2 years. And the clinical diagnosis: schizophrenia formed 88% of the total population, and the mean duration of the illness in the total sample is 16.5 years. Mean duration of the treatment is 13 years. And usage of the antipsychotics in the total sample, majority of the population was on at least one second generation antipsychotic. Only 2.7% were on only first generation antipsychotic, and the most common antipsychotic used in the population was risperidone, which is followed by clozapine. And 25 patients, which is 55.5%, were on more than one antipsychotic. And majority in the population who were on more than one antipsychotic, they are usually on combination of first and second generation. The frequency of risk factors in the total population, 45, that means 60.8% met the criteria for metabolic syndrome. Another 13% were subsyndromal level who met 2 criteria. And among all the risk factors, central obesity was the commonest, which is seen in 81%. All the risk factors and metabolic syndrome was more prevalent in females rather than males, except for waist circumference and hypertension, which was seen most commonly in males. Age-wise distribution: most common age group with metabolic syndrome is 31 to 40 years of age, and females have a mean age of 41.2 and males have 45.6. So females have earlier age of onset compared to males. And the age distribution, as I told you, the orange part is 31 to 40 years, and in both males and females, 31 to 40 years age group have more prevalence. And in the population who were found positive for metabolic syndrome, majority were on atypical antipsychotics. 98% were receiving at least one atypical antipsychotic, and 25 were receiving more than one antipsychotic. And most common was clozapine in the population who was found positive for metabolic syndrome, which is followed by risperidone. And when we see the other way, for clozapine users, almost 88% of clozapine users were found positive for metabolic syndrome, which is followed by olanzapine and amisulpride. 60.8% met the criteria for metabolic syndrome, which is significantly higher than the general population, which is 13 to 20% in India. And also in psychiatric population, which is done by other studies, KT shows the risk of 40.9%, and the study by McAvoy shows the risk as 43%. Females show more prevalence than that of males, which is also seen in other studies done on psychiatric patients, but it is contrary to that found in general population. And males show more prevalence of central obesity and hypertension compared to females. And all the remaining factors of metabolic syndrome, females show more prevalence. Mean age of patients with metabolic syndrome is 43.5, and females have a low mean age. 43% of female patients with metabolic syndrome were under the age of 40, while only 37% of males were under the age of 40. Among all variables, waist circumference was most common, which is seen in 81% of the total population, which is followed by low high density lipoprotein level, which is found in which is also found in 60.8% of patients. There is a very strong association found between atypical or second generation antipsychotics and metabolic syndrome. In patients who met the criteria, 98% were on at least one atypical antipsychotic, clozapine being the most common, followed by risperidone. Clozapine causes metabolic syndrome in at least 87% of patients, followed by olanzapine and amisulpride, and risperidone, quetiapine in the same order. Conclusion: patients with chronic mental illness have 2 to 3 times increased risk of metabolic syndrome compared to general population. The risk is higher with the usage of second generation antipsychotics, clozapine being the most common antipsychotic associated with metabolic syndrome. Female patients who are on atypical antipsychotics have increased risk and earlier age of onset, and central obesity is much more common in males than in females. Limitations of the study are, as the patients were as the mean duration of the illness is 16.5 and they were on medication for quite a long period, the baseline values for the same parameters could not be obtained for the patients, and genetic predisposition to metabolic syndrome in the study population was not taken into consideration, and few patients were on more than one antipsychotic, so the association with the antipsychotic was not precise. And the implication, it should be made a practice to keep an eye on metabolic syndrome and measures to minimize it to whomever we prescribe antipsychotics, and appropriate suggestions for lifestyle modification should be incorporated in the routine clinical care.
Questions, please. Dr. Srinivas.
See, in your study, you have just observed the metabolic syndrome among the patients, right? You have not correlated that because of the use of the antipsychotics, the abdominal obesity is increasing over time.
Only question,
so
no comment.
How does this, you don't have a baseline, or you are not following the patients also? So, and again, you said there is a difference.
Can you please ask the question? Sorry to interrupt you, but please ask
two
the question.
Questions, sir. One, why it was not followed up, whether over a period of time, whether it is increasing or not. And the other thing is, there is a difference between male and female, whether it is statistically significant or not was not done. And so over graphs you are showing some difference, but the statistical significance of the difference was not done there. And you can use a WHO criteria for this obesity assessment.
No more. Only questions, please. Sorry to talk like that, but
Actually, International Diabetes Federation criteria, this considered, before making it, they considered WHO, American Heart Association and all the criteria, and they thought central obesity is a must factor, so they made it mandatory. The components are same, but the difference between other and this is that central obesity should be must, and in the remaining 4 factors, 2 should be positive. But this is the latest one, and they have considered other also before making the criteria, so we thought it is more reliable for doing this. And this is just an observational study, so we didn't try to compare with population. And the following up, this was done in a rehabilitation center. So the
Can you
majority
put that
of the-
slide later on, please? Please don't put that slide now.
So the majority of the population were very chronically ill patients. So the baseline values were actually not available.
No, not the
Did you
baseline.
answer the second
Medication was
question?
started.
Medication
Yeah, if you
was
can answer the second question, what he has asked.
Statistical. Not done.
So,
Use the mic.
so the
People are
difference
not
does
able
not
to hear.
carry any meaning unless there is a statistical significance there.
Yeah, Dr. Shesh Kumar or yeah, then Girish. Okay, Girish, please.
Why you have chosen this study? Any compared to previous studies, any significance to your study?
One thing we wanted to see in patients who were in rehabilitation center, because they lead more kind of sedentary lifestyle compared to others. So the significance is the risk is much more than the previous studies.
Dr. Shesh Kumar. You can give that mic to Dr. Shesh Kumar.
Did you exclude medical illnesses?
Sir, actually the criteria for medical metabolic syndrome, history of diabetes or history of dyslipidemia or history of hypertension, they should be included in the criteria. We cannot exclude like that.
Did you investigate?
Yes, sir. All these three things we investigated.
Any more questions? I think with that we end the session. Thank you, Dr. Maithili, for presenting this lesson. I thank the organizers for giving us the opportunity to chair.
And all these three papers probably satisfied the appetite of my co-chair, Dr. Anand's statistical appetite.
So this concludes our today's session. We'll be breaking away for high tea, followed by AGGM meeting later. Thank you.